Coming up on Mayo Clinic Q&A.
About 85% of patients will have an orthostatic headache, one that gets worse when they stand up, better when they lie down. But even those patients, and then the rest of the patients have other things like dizziness, ringing in the ears, sometimes double vision or changes in vision. There's even a type of dementia that can be caused by when the brain sags down so much.
These conditions are often caused by membranes surrounding the brain or the spinal cord leaking cerebral spinal fluid. This fluid provides cushioning, and if the leak is not treated, it can cause long-lasting harm to the brain or the spinal cord.
It's debilitating. It can go on for years. We're doing our best to educate both patients and providers on how to recognize it, because whether that means someone can get treatment locally or be referred here, we want to help, because this is usually a treatable, reversible condition.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Cerebrospinal fluid, or CSF, is the clear fluid that surrounds the brain and spinal cord. CSF cushions the brain and spinal cord from injury, delivers nutrients, and acts as a waste removal system for the brain. A CSF leak occurs when fluid escapes through a small tear or hole in the outermost layer of tissue that surrounds the brain or the spinal cord. CSF leaks can occur in the brain or at any point along the spinal column. So how are CSF leaks diagnosed and treated? Well, believe it or not, here at Mayo Clinic, we have scientists and physicians who are experts exactly in that topic. Joining us to discuss this today is Mayo Clinic neurologist, Dr. Jeremy Cutsforth-Gregory. Thanks for being here today, Jeremy.
Thanks, Helena. It's great to be here. I really appreciate it.
Well, I like to learn something new every day, as our listeners know. And I have to say that this is one of those topics that I don't think that a lot of people probably know a lot about.
That's right. I mean, we'll talk about a couple different types of CSF leaks today, but all of them I think are under-recognized. And it's important to recognize them because we can treat them, as you know.
It's interesting because you see a lot of patients with this issue.
I do, yeah. Part of it is the referral bias, right? Aren't too many centers in the country that are really expert in these spinal CSF leaks, though we're one of them. And so I get to see these patients almost every day.
So how common are CSF leaks?
The data are not the strongest, but they would say perhaps 5 per 100,000 people, but that's a gross minimum. I think I've got to be seeing more than that. And I think if we were to do an epidemiologic study, we'd see the number is at least double that.
Wow, I was going to say, I feel like you see many more patients than that quite frequently, but that's interesting. Can you tell us a little bit about the difference between leaks that occur around the brain or skull base and spinal cord? Do they have differences?
For sure. And I think that's probably the most important kind of breakdown that we make right off the bat, which is leaks that come either out the nose or out the ear, what we call skull base leaks, and leaks that occur along the spine, because the symptoms are different, the treatments are different. So first with skull base leaks, that's usually in patients if they don't have trauma or neurosurgery. So we're talking about spontaneous issues here. It's patients with high pressure inside the head. And that can happen in young women who are overweight, would be the most common. And that's not the same for spinal leaks. That can be almost anyone. And the symptoms of a high pressure headache, worse at night, you wake up with the headache in the morning and you get leakage. You can lean forward and drip, 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 out it comes.
Oh, interesting.
The spinal leak patients, they stand up and they get a headache. So I know in your practice, you treat a lot of patients who get spinal taps or who have the aftermath of a spinal tap. It's similar. They stand up, they have a headache, they lie down, they usually feel a bit better. There's a whole wide range of other symptoms, but that's the most common one. And that's from a spinal leak, not from a skull base leak.
Okay. So is that the only symptom or side effect that someone might experience if they were having a CSF leak and would come to medical attention, is the headaches?
No, it's not. And that's probably why it's not recognized very often. About 85% of patients will have an orthostatic headache, one that gets worse when they stand up, better when they lie down. But even those patients, and then the rest of the patients have other things like dizziness, ringing in the ears, sometimes double vision or changes in vision. There's even a type of dementia that can be caused by when the brain sags down so much, which I'm sure we'll talk about later, that it puts pressure on certain regions and can cause a frontotemporal dementia. So it's a wide range of things. And I think that's probably why the diagnosis doesn't always come to people's mind.
Are there certain risk factors that would lend itself to someone developing this?
Yeah, the most common risk factor for the spinal CSF leak is joint hypermobility. So maybe this patient actually has connective tissue disease like Marfan's or Ehlers-Danlos, but often they just have a degree of kind of double jointedness. So I'll ask patients about that, including, can you bend your elbows backwards, or can you touch your fingers if you reach over above and below behind your back? Or have you ever dislocated a shoulder or a hip? They pop out of joint, because that can be a risk factor that maybe their connective tissues are looser or more prone to leaking. And we probably should put a name to that too. So we talked about the lining that of the brain and the spinal cord, and it's called the meninges. It has different layers. The outermost layer is called the dura. So sometimes people will have a tear in the dura, or they'll call it a tear in the meninges, or inflammation is called meningitis. The terms get a little bit messy, but it's that outer layer, just like you said at the start.
Interesting. How do you diagnose a CSF leak?
It starts with the story, right? So I'm asking patients, if they come to me with headaches as the most common symptom, how did it start? Did it come on all of a sudden, which is what you might expect for someone who suddenly developed a tear and a leak? Or was it something that you had a couple days a week and then every day and then now around the clock? Is it worse when you're upright? It's important to know sometimes people start out with a headache that's worse when they're upright, but over time it just develops a headache around the clock. And so if I don't ask them about how the headache was at the start, I won't be thinking about it. Once I have a clinical suspicion, then I go for imaging. And the first test really is MRI scan of the brain, because it'll show changes, either the brain sagging down from where it belongs, or that meninges, the outer layer, getting thicker and taking up the contrast dye more than normal.
Interesting. So are there different types of CSF leaks that happen in the spinal column?
Yeah, they're now recognized kind of three big types. So the first one would be a bone spur that cuts through the dura or the meninges and causes a leak. And I think that's probably the easiest to visualize or conceptualize. Those tend to be what we call fast leaks. It doesn't mean the symptoms are worse. It's just that the flow of fluid leaking out is actually faster and builds up pockets that we can see on an MRI scan. This next most common is something that would be where the nerve exits the spinal cord. It has to exit out through the dura. I think of it kind of like a sleeve, right? There's a little bit of lining that holds all the fluid in. Well, sometimes right in the armpit or around that sleeve somewhere, it gets a tear. So that's a type 2 leak. It's a tear in the nerve root sleeve. And then the most recent, and this is the one where we've made a lot of advances recently, is called a fistula. So a fistula is two tubes that connect that aren't supposed to. Well, if the nerve root sleeve connects to a vein, it lets the spinal fluid escape, but it's not just going out into the soft tissues. It's actually into the bloodstream and washing away like a little siphon. And the very first fistula was described in 2014. And that doesn't mean they didn't exist until then, but we didn't even know they existed until then. And so just in the last 7 years, we made big progress in figuring out how to find a fistula, sometimes some clinical features that make us more suspicious of the fistula type versus the other ones, and then a new treatment too. And I hope you'll ask about that, because I'd love to talk about the treatments of fistulas.
Well, what a wonderful opener for me. Jeremy, tell me about the treatment for CSF leaks.
Yeah, so the type 1 and the type 2, I get to rely on you and your colleagues doing blood patches. So it's putting a needle in near the spinal sac, near the dura, and injecting the patient's own blood to try to kind of clot it off, cover the hole, let it form a scar. And that works for the type 1 sometimes, definitely works for the type 2 leaks. But the fistula, that blood actually can't get into that internal hole. And so for that, we'll do a catheter through the groin, snake it up into the spine, and then glue the vein shut from inside. It's a minimally invasive and very effective treatment that in the past, we would have had to have done a spine surgery to cut open the spine and correct, but now we can do it through a catheter-based process. Mayo is a fantastic place to get to make those kind of advances.
Yes, because you do see so many patients who have this issue that allows even those who treat it to be more helpful to you.
Yes.
To have experience. Are there any expected side effects or complications from the treatments that are delivered?
Yeah, the most common one is actually when the treatment works too well, by which I mean, you plug the hole, but the patient has been living in that kind of low pressure state. And so the body compensates by overproducing spinal fluid. So then when you correct it, they go into a rebound high pressure state for a period of time. It's usually pretty mild, usually doesn't last more than a few days or maybe a couple of weeks, but there are occasional patients who we need to put temporarily on a medication to reduce spinal fluid production until they kind of equilibrate back to a normal level. So we call that rebound intracranial hypertension, but it's really a good sign. It means the treatment worked.
How often do you have to repeat the treatment?
So if we do a blood patch, it really depends if the patch is at the site of the leak. So the treatment is important, but finding where to apply the treatment is actually the most important step. And if we know where the patient's leak is, 1 or 2 blood patches usually is pretty effective. And if not, then maybe we consider a surgery. If we don't know where the leak is and we're doing blood patches, kind of just wherever it's safe or maybe at a couple good guesses, often we'll be doing a series of blood patches every few months for those patients. So it really depends. And when the treatment isn't working, to me, the takeaway is we haven't found the leak. We need to go looking for the leak again.
That's interesting. I think one of the things that strikes me the most about these patients when I have the opportunity to assist you in caring for them is the incredible struggle that they go through getting to a diagnosis. So sometimes, you can explain this better than I can, but there's patients who have probably years of treatment or management for other types of headaches or other presumed issues before they get to this diagnosis.
Yeah, unfortunately, that's exactly true. Patients who have had at least months, if not years, of headaches that have been called migraines. They might even have some features of migraines, but they never respond to migraine drugs. So patients put through months and months of medication trials. And to me, I say, but really the key feature is if you're lying down and feeling better, it's probably not a migraine. Migraine has to get better with sleep, not just lying flat. If they have the dementia, if someone isn't aware that this is one of the rare causes of a dementia mimic, they can be treated with dementia for years. I just saw a patient like that recently, and she's having one of those embolization, the glue it shut procedures next week, and really looking forward to seeing her get better. It's debilitating. It can go on for years. We're doing our best to educate both patients and providers on how to recognize it, because whether that means someone can get treatment locally or be referred here, we want to help, because this is usually a treatable, reversible condition.
And what is amazing to me is that it seems that with whichever treatment they qualify for based on their leak, that often the response is pretty quick. Whether it worked fairly soon.
Yeah, a lot of people, the same day, sometimes even on the table. I'm not the one doing the blood patch, but I'll ask them, when did you start to feel better? And it's probably when they're with you, right? They say, oh, my hearing, it cleared up right away, or my headache started to get better right on the table. And it's gratifying for me, and I'm not the one in the moment. So I imagine it's fun for you too.
Yeah, it's often when they sit up or get up to walk out, they're feeling much better. That is really gratifying. Jeremy, are there any medical therapies that you use to treat CSF leaks?
Sadly, they're not medications that are going to help these headaches much. Occasionally, we'll do a short burst of steroids to try to kind of buy just a little bit of time to get the workup completed. But for the most part, it's a matter of expediting the workup to find the leak and give a blood patch. I mentioned a medication to temporarily lower pressure after treatment. So that's probably about the only time I end up using pills.
That's interesting, because I can imagine that you probably then see patients who've been through a lot of different medical therapies before they make it to you to have an actual diagnosis.
Yeah, that's right. And so one of the things I'm often doing is taking things off their medication list, and outlining ways to titrate off these medications.
Sure. Anything else you'd like to share with us today about CSF leaks?
No, I'd really just highlight that what it takes is a multidisciplinary team. And I think that's why Mayo Clinic's able to do this. So I'm a neurologist and maybe are the kind of the front line assessing these patients, but I couldn't do it without anesthesiologists to do the blood patches, radiologists to do and interpret the scans that are sometimes quite subtle, and occasionally a surgeon to fix when we can't do it other ways. So it's a multidisciplinary effort. It's a great privilege to be part of that team, and here's a place we can do it well.
Jeremy, we've been talking that during COVID, we've increased the use of telemedicine or virtual visits for some of our clinical areas. Do the patients that you see benefit from virtual visits either before they see you or afterward, or is that not something that you can do a virtual visit for?
We've done it both ways, and there are certainly times where it works. So that initial evaluation, I can get a story by telehealth quite well and save the patient the trip and kind of outline, okay, so which tests are we likely going to need, and get them pre-scheduled. So we've done a fair bit of that. And then after a blood patch or after any sort of treatment, we've now put in place a video visit with our nurse who's quite experienced with this, kind of at the 1 month mark. So the patients know there's going to be a time to give a status update. It's offloaded the clinical schedule just a little bit so we can keep seeing new patients. And then we know at the 1 month mark, do we need to do another treatment, more testing, or is the patient doing well? So we're using telehealth for sure. Now they have to come here to get the high quality imaging and to get the treatments. But if we can, start and end telehealth, I think it's saving a lot of people some time and convenience.
And a real confidence booster for patients, knowing that when they go home, they can still have continuity of care with us.
Yes, it's definitely been a nice way to stay connected.
Well, thanks for being here today, Jeremy.
Thank you, Helena, very much.
Our thanks to Mayo Clinic neurologist, Dr. Jeremy Cutsforth-Gregory, for being here today to discuss cerebrospinal fluid leaks, how they are diagnosed and how they're managed. I hope that you learned something. I know that I did. And we wish each of you a very wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.